Let's talk about pulmonary artery catheters. These are catheters that we can use to evaluate the pressures in the right side of the heart, as well as getting an estimate for the left ventricular and diastolic pressure. And also we can use it to obtain cardiac outputs and cardiac index for patients who were weaning off of hemodynamic support. Now, data around pulmonary arterial catheters or Swan Ganz catheters has been pretty mixed, and it hasn't really been shown to increase benefit for patients in terms of hemodynamic monitorings. But in any CVICU or cardiovascular ICU, you're going to see these catheters, and it's helpful to know the anatomy of where it is in the body, as well as the anatomy of the catheter itself, because there's multiple different ports that we're managing. Now, how do we know where we are in the body with this catheter when we're placing it? Typically, we do it using the transducer on the tip of it, so that tip of the catheter can basically tell us what pressure it's reading. So as we're going through the SVC into the right atrium, into the RV, and into the PA, we can see the pressure waveforms changing as we enter those different chambers. And also we have something called the rule of tens, which basically tell us the different distances and where we think we are in the heart. Now, there's a balloon at the tip of the catheter that basically helps float it into the PA. So once you're about 20 centimeters in and you're confident that you're in the RA, you'll have someone inflate the balloon for you. And then you typically advance the catheter with every heartbeat, hoping that the stroke volume of the right side will basically guide your catheter into the RV. There's also the natural curvature of the catheter itself, which helps take that curve around the outflow tract. And then eventually, as you see it get advanced and you see the pressure waveforms change, you'll see yourself get into the pulmonary artery. Now, patients who have more complex anatomy, like if they're post-heart transplants, a lot of these catheters may be placed in underfluoroscopy, like in a cath lab, and that's where they take x-rays to really get an estimate as to where that catheter is as they're advancing it. In the operating room, we also have the advantage of using transesophageal echo, so that might be another aid in helping us figure out where a catheter is if we're having trouble placing it. So in terms of the pressure waveforms, the biggest difference you'll see going from the RA to the RV is a big increase in the systolic pressure. And then as you're transitioning from the RV into the pulmonary artery, you'll see a diastolic increase in that waveform, as well as a dichrotic notch, which lets you know that you're in the pulmonary artery. Once the patient's in the ICU and you're getting chest x-rays to confirm placement, you basically want to make sure that the catheter is in zone 3 or the most inferior portion of the lungs, and then you also don't want it going past 3 to 5 centimeters from midline. If it does go past that far, then you might want to withdraw your catheter. Now let's talk about the catheter a little bit. So there's 5 extensions that come off the distal tip of it. Let's start with the balloon insertion point. So the balloon inflation point is where you're going to attach a syringe and inject no more than 1.5 mLs of air to blow up that balloon, which is how you're going to guide your catheter into the right place. Next, you have your distal PA port. So this is where the tip of the catheter is going to be communicating with this port, and we basically use it just to transduce the pressure that's at the tip of the catheter. This is how we get our continuous pulmonary artery numbers, but if we want to wedge it, we go up with a balloon, advance the catheter, and then this distal port would give us what the left atrium pressure is reading. Next, we have the proximal drug infusion port, so we can use this both for CVP measures as well as infusions of medications. The fenestration of this on the catheter itself is 30 centimeters from the tip, so it lives in the SVC. Lastly, you have your thermistor port, which gives you continuous temperature readings, and it reads it just proximal to where the balloon is. It's also very useful for when we're doing thermodilution cardiac output readings. And that's a quick overview of pulmonary artery catheters.